Well, hello, everybody. I'm Dr. Robert Kane, and we're here today with Dr. Hal Blackman. And Dr. Blackman is a physician with offices in Cincinnati, Ohio, and New York, New York currently. He's been practicing for a very long time. We've known each other for, gosh, probably 15, 20 years now. And Dr. Blackman's specialty is pain and pain management. So we're going to talk a little bit today about how we incorporate thermography into a pain management practice. And Dr. Blackman's also going to give us some tips for how to identify pain and how to relieve it when possible. So welcome, Dr. Blackman. Nice to have you here.
Thank you, Robert. It's just a pleasure to be here and wonderful to see you in person after all these years.
I know it's been the benefit of COVID and Zoom technology is that all these clients that I've had who I've only seen pictures of, I can actually talk to you and see your face.
Right. I really do like that part of it. And I like that we can do so much from wherever we are in the world, which is also really nice.
Absolutely. Absolutely. So, Dr. Blackman, why don't you start off telling us a little bit about yourself, your practice, and what you're doing out there so people can get an idea of who you are and what you're bringing to the world of pain management.
Well, we've developed an expertise in fascia. One of my mentors early in my career was Dr. Janet Travell. She pretty much wrote the book on myofascial pain and fascia integrity and all that piece of how that causes pain in our body and really got me started out. I was able to meet her directly and learn a lot from her. She was one of President Kennedy's physicians in the White House for his back pain, if anyone is old enough to be familiar and remember that. So I had a
Mhm.
wonderful start. And we've evolved a lot of that work, learned a lot. And, in pain management, most of pain management is how do you manage it? How do you live with it? How do you cope with it? That's not really our conversation. We look at pain through a much different lens, and you don't have to learn how to cope with it if you can make it go away.
Mm.
And so our conversation is how do you find it? How do you locate it? What has to happen to your body for the pain to leave? And we teach that to people and we teach that to doctors. And in the middle of this is thermography.
Well, that's great because, as a chiropractor, we've always been trained to look for the cause rather than just manage the symptoms. Of
Right.
course, when someone's in pain, we want to be cognizant of the symptoms, but if we can get the thing to go away, that's the goal.
hmm And
So,
oftentimes an adjustment will work, but anything that works, no matter what we call it, cupping, acupuncture, dry needling, prolotherapy, trigger point injections, whatever you're doing, from what we've started to see and the lens that we've started to look through, the part of whatever you're doing that actually works to make pain go away changes the fascia
mm.
and changes what's going on in the fascia so that the reporting to our brain of the fascia problems tones down.
So you're seeing a huge component of the fascia in the creation of a pain syndrome and the maintenance of chronic pain. If I'm hearing that correctly?
80%, 80% of the information that comes to our brain from our periphery is the teeny tiny nerve endings, just plain nerve endings in between the strings and cords of fascia, telling us about the kinks that we call trigger points and telling us about where we hold together and we've injured that.
Okay.
And that's the information we're getting. And we interpret that in many ways. We can talk about that toward the end because at that time we can talk about how to make pain go away.
Mm-hmm.
Do you want to go back and focus on thermography?
Well, let's talk about how you are getting that information. How are you identifying these fascial problems and the components of the pain syndrome? And then, of course, since everyone that's going to be watching this is interested in thermography, how do you incorporate the thermogram into that process of identification?
All right. So when we go to look for pain and try to figure it out, we've developed 5 rules. I call it the Blackman 5 rules of pain CSI.
Mm-hmm.
How do you figure out who done it?
Right.
And the first rule is pain doesn't come from where you feel it. Your headache is not coming from your head. The pain in your left arm could be your heart attack. The pain in your knee joint comes not mostly from your joint. Just talk to your friends and relatives who've had their knee replaced. There's no joint there and the knee still hurts. Rule number 2, contrary to everything we've been taught from day one, our brain can't tell the difference between numbness, tingling, burning, itch, tickle, sharp, dull, achy, stabbing, and even sexual arousal. They all come from these same nerve endings in between the strings and cords of our fascia. Reporting this and these injuries and what's going on in there. And that information comes to our brain and we can't differentiate. That's how you get in the ring with Mike Tyson. He bites your ear off, it really hurts.
Mm-hmm.
You get close to someone that really cares about you and they touch your ear in a very different way and you have a much different physiologic response. It's the same nervous system and the same skin that's giving you that information, and you have two totally different ways to distinguish that.
Mm-hmm.
So when we're taught in medicine that burning pain and radiating numbness and those things mean nerve and disc and so forth and so on, that's really not true.
Mm.
They can, but most of the time that's a fascia pain, has nothing to do with the nervous system as we were taught to understand.
Oh, interesting.
Rule number 3, if you can't believe where it comes from and you can't believe what it feels like, what can you believe? And that's rule number 3. And the only thing you can believe is that where you are specifically tender, millimeter by millimeter, is where your fascia strings are kinked and tied in a knot, or where they attach and anchor and hold you together, and you've injured them repeatedly over many years, and that tenderness is a residual of those injuries. There's some wonderful examples everybody can try while they're sitting and watching this. The sternocleidomastoid muscle comes right through here in the neck, and it's about this big. You can take your index finger and your thumb, wrap them around this muscle, and feel cords and ropes within this muscle, and you can also feel that in some places they're surprisingly tender. You get that idea?
Yeah.
Well, these are
the
the
spot
kinks.
right here.
Right. And the most tender of these is where this kink is going on.
Mm-hmm.
And the nerve endings in between are measuring pressure and friction. And this is all about pressure. And when these nerve endings are already squished by the kink, trigger point, knot, whatever we want to call it, and then you add a little bit more pressure on the outside, well, you feel that. And an inch away where you don't have the kink, but you still have that tight ropey band, you can't push hard enough to make that hurt. Okay, so
Right.
now let's look, how do you find the injury? Take your finger and touch not the front of your collarbone, but push in on your neck and push down on your collarbone. And feel the little lumpy irregularities that are also surprisingly tender. Feel that?
Mm-hmm.
That's the injury that causes this and allows this to happen. And you might have gotten the first start on those injuries when you were in nursery school. Great place. The color of your lunchbox might have been important to your classmate. They didn't like it and they came up behind you right before morning recess and shoved you to the ground.
Mm-hmm.
Snapped your head back and tore where the fascia from this muscle weaves to the cover over your bone. And when the cable snaps, the strings and cords within the muscle twist into this knot we call the trigger point, creating that ropey band. That's how this forms. At least that's the way I picture it formed.
Yeah.
And then this is the pain that comes from it. So you may find that this is still a little warm. You may find that this other part of the injury up here is still a little warm, but these X's represent the kinks in the fascia, and these red speckles represent the pain pattern that comes from it. And then you can't differentiate numbness, tingling, burning, itch, tickle, sharp, dull, achy, but they'll be within that distribution. So the location of your symptoms is important, but how you interpret them is of minimal value and of very little diagnostic significance.
Mm.
Rule number 4.
So just before you go to rule number 4, just
Yeah.
to summarize what you're saying is that we have an area of pain. We just have to be careful not to say that's the cause of the pain, that the cause is actually in the area. We need to look at that area, but be aware that there may be referral zones that are sending pain signals to that area. And that's just where for lack of a better description, the periscope is rising, showing us there's something underneath the surface.
And the nerve endings in between these fascia cords telling you about this are 80% of the information that comes to our brain from our periphery.
Mm-hmm.
So any other sources of pain or discomfort are dwarfed by the magnitude of this information.
Mm-hmm.
So I can't say this is all the pain in the body. I won't pretend to do that. But if you can change 80% and at least change 50%, now we're talking about making pain go away. We're not talking about coping.
Yeah,
So
yeah, that's 80% is a great statistic.
rule number 4, the places where you are most tender throughout your whole body as we examine you this way generally represent the injuries and kinks that have formed through your lifetime that generate most of the pain of which you are conscious. So maybe the people that are listening, you found this was tender, but you're not really aware of it. And you noticed this one was tender, but you're not really aware of it. This is under your radar. The places where you are in pain are right in your face and way more tender than the ones that are not in your radar. So what that tells us all is that nowhere do you need to be perfectly restored. Everywhere you need to be 99% ignorable.
Mm-hmm.
And that's achievable and reasonable to hope for. And that gives everyone with chronic pain who's been taught that you need to suffer with this forever, because that's what we're taught. If you have pain from your injury and it lasts more than 3 months or some arbitrary number, then poof, it's turned into chronic pain, and all we can do is make your brain not work, make your nervous system not work, ablate it, kill it,
Right.
give it drugs and medicine. That's what we've got, and that's what we call pain management, is to do enough of that and combine that with enough drugs that we make all those things happen, and you can ignore these injuries and what's been going on in your body.
Mm-hmm.
We prefer to find them, show them to you, and then help you make them go away.
I think that's a better approach, especially given that some of these continue to deteriorate, and whatever strategy you did to ignore the pain, be it surgical or medication, can eventually run its course and no longer be effective. And you're
Now,
ignoring those
sometimes,
signals.
right, and sometimes even our physical exam is not enough to show things deep under the surface, because there's people with really thick body parts.
Mm-hmm.
There's people who have arms as thick as my thighs, and maybe they've got a lot of muscle strength, and they're an athlete, for example, and I can't push hard enough to make them appreciate, with all their lack of pain sensitivity in that area because they're used to it, I can't really show them and help them see where the pain comes from by this tenderness that I'm describing. And then we take out the infrared imager and look at it with the camera,
Mm-hmm.
and then have them stress out the body part. So if it's a picture, maybe they can throw 30 or 40 of them, and we'll watch what part of their shoulder heats up and gets inflamed. Or maybe we'll have them jump up and down if it's a leg problem, and watch their leg change with time. Even in 5 or 10 minutes, oftentimes things will light up from deep underneath that are much harder to appreciate from the outside.
Mm-hmm.
That's a really good place to use this.
Yeah. So let's talk a little bit more about the usage, because you just brought us exactly where we want to be. If somebody's coming in and we suspect a myofascial component, which, from what our brief conversation, we're always expecting a myofascial component.
Right.
Somebody comes in, let's say they have something going on in their neck or or in their upper extremity, and let's say we do an upper body scan. So we do the head, the neck, the torso, the arms, and the hands. Now, in those thermal patterns that we're looking at, we're going to see a variety of different things. We'll see hot spots, we'll see blushing, we'll see cooling trends that might suggest neuropathy. How are you interpreting the images and combining that with your other examination findings to truly identify the cause?
We start out with our hands. We always start out with hands. And one of the downfalls of our medical education is we're not taught how to touch. So this whole exam technique is so foreign to where we came from. And so we look to a diagnostic test, And thermography is such an example for that. Many people will go to that sooner than we will because we don't need to do that till we run out of room for touch to help you heal. And we're really mystified. So now you look at the body and you go, well, what does warm represent? What does cool represent? And yes, if you're looking for a neuropathy from a disc, sometimes you will see that streak coming out from the spine, and that's remarkable when you see it.
Mm-hmm.
Very rarely in our experience does the disc really cause the issue. It's almost always the fascia. Even the radiating pain down your leg, even the numbness in your foot is often from a fascia injury where we're taught that it's coming from nerve. We can talk about that as soon as we finish this piece. I've got a wonderful story that helps illustrate that.
Mm-hmm. In terms of the identification, if you're looking for, a myofascial trigger point, that trigger zone that is the source of the referral, are you looking for in specifically thermographically for any finding? Is it a hot spot? Is it a cold spot? Is it both? Are there findings in both the referral zone and the actual source? How does that description come across?
There's findings in both, and they're really variable. Sometimes they're hot, sometimes they're cool. They're really tight, it cuts off blood supply.
Mm-hmm.
Things underneath can be cool. When the body is inflamed, most of the really intense pain that comes from the fascia is an interaction of the immune system with the fascia. You have these injuries all over your body. What makes them light up like you just plugged them in versus not?
Mm-hmm.
What makes the difference between a good day and a bad day? What makes you wake up with a stiff neck in the morning when you didn't have it last night? I'm going to suggest that most of that is an inflammatory reaction in our food, in our fascia, set off by what our immune system does to our food.
Mm-hmm.
You eat inflammatory food, you tend to light up. So that lighting up is going to make these areas hot and make them warm. So you're going to start to see an inflammatory reaction in the fascia from food and environmental toxicity that ramps up all these hot spots all over the body. That's pretty interesting to see.
Yeah. Yeah. And to get some objective information as to where things are coming from and how they're affecting remote areas can be really beneficial.
And as people calm down that inflammatory reaction by changing their food, and you can actually go to our website, blackmanhealthandwellness.com, sign up for the newsletter and download the short form of what we call the do not eat list, which, whatever diet you call it, Mediterranean, keto, Whole30, paleo, whatever name you gave it, the names are not important and the diet is not really that important. What's really important is what those mannerisms have in common is they tell you to avoid most of what we call the do not eat list.
Right. The
If you
inflammatory.
avoid that, it doesn't matter what you call the other end. And there's no one diet appropriate for every person, but there is a do not eat list that works for our entire species.
Mm-hmm.
And then for you as an individual, there may be some other things to add to that list, which has been fascinating to us. And for people who look at the list and say, well, I can eat that and it doesn't bother me, it means that you have enough resilience that your body can do that with it.
Mm-hmm.
But at the same time, you're wearing out that resilience more quickly than you ever imagined.
Right. Well, you were talking about there's a threshold before we actually start to feel it. And if
Right.
you're bombarding yourself with inflammatory foods, in addition to doing activities of daily living in a way that might be irritative or aggravating, we just keep bumping up closer to that threshold. And then eventually we hit it, and now the pain receptors are firing.
Yes.
Yeah.
Another really good thing for thermography is to diagnose carpal tunnel syndrome.
Mm-hmm.
That's a lot of fun.
Let's talk about that.
A lot of docs are taught that the definitive test for carpal tunnel syndrome is to put needles and shock the arm. It's an electromyography, EMG test, and you're measuring where the nerve is interrupted because the signal down here that comes from the shock up here doesn't get through so well. And you can tell that the nerves don't transmit so well. Well, That's not a very comfortable test. It's not a lot of fun. And there's an easier way if you have access to thermography is you put the hand in a plastic bag and you put it dry into very cold water, ice cubes and water, and you cool it down. And then you take the hand up and you take images of it and you watch and see how it warms up. And if it warms up, if the parts that are not innervated by the median nerve warm up first, then you've got carpal tunnel syndrome almost all the time.
Interesting. A very interesting variation on the cold challenge. I hadn't thought
This,
about
these fingers will warm up and these fingers will stay cool, and so will the part of the palm that's innervated by the median nerve.
that.
It's really fascinating.
Yeah.
So
How long do you keep capturing for?
5 minutes,
Yeah.
maybe 10, you'll see it happen. And once you see it happen, the rest is just your curiosity.
Right. And are you using video or can you do still capture?
You can do still capture if you shoot one, every 15 seconds.
Mm-hmm.
That's really enough.
Yeah.
The time exposure is the easiest,
Mm-hmm.
but you're really you're showing the beginning and the middle and the end and the transition. And you need to catch it before the whole hand warms up so you can see the difference.
Right.
And then it kind of looks just like the pictures, where the sensation is when you draw the dermatomes on the extremity. It looks just like that picture without the colors.
Mm-hmm. Interesting. So do you find a lot of those carpal tunnels get picked up in the cold challenge, but get missed on the standard scan?
I don't advocate for the standard scan.
Mm-hmm.
It's uncomfortable. And a lot of times, if you want to know if somebody's got carpal tunnel
Well,
syndrome.
no. When I say standard scan, I mean the standard thermographic scan.
So
If I just do a plain unchallenged upper body series and I'm looking at the hands,
you won't see it.
you won't see it. You're only going to see it
likely.
on the challenge.
Right.
Now that's excellent. I'm going to start incorporating that in my trainings and teach the technicians that I'm working with how to do this because this could be really, really valuable.
Another place to use this is to find out where is blood flow.
Mm-hmm.
You can go to the surgeons and say, well, you've got a diabetic with a diabetic neuropathy, and the toe is really bad and you're going to have to take it off. Is it going to heal? Does it have enough blood flow to heal? How cold is that foot? And where does it still have blood flow to heal skin?
Mm-hmm.
And you may find that none of the toes have enough blood flow to heal and the amputation has to go a little higher. Or you may find that you need to do something to improve blood flow before you tackle this wound. If the wound isn't healing, you can find out if it's got blood flow to it through this same kind of exam.
Mm-hmm.
Another good use for a thermogram.
Yeah. And also, you mentioned previously, before we started the interview, the idea of using it for CRPS as well.
Yes.
So let's talk about that a little bit because we've got cold challenges there. We've got plain images. How are you using it, and what are you looking for?
Well, at the heart of CRPS or RSD is myofascial pain.
Mm-hmm.
That's really where it comes from. The difference between myofascial pain and CRPS is the difference between a headache and a migraine. That doesn't go away. And so you have an injury to the fascia. You've inflamed that even more by toxicity to food and environmental poisons. You've tightened beyond control. And now you've got metabolic waste in the area that's also contributing to the issue.
Mm-hmm.
But at the heart of the pain are the nerve endings in between the strings and cords of your fascia reporting this information. Now, the nervous system that transmits this pain doesn't know left to right, doesn't know front to back, doesn't know up to down. It's the autonomic nervous system, and it also controls how you regulate temperature. So when your autonomic nervous system goes out to lunch, so to speak, you can't regulate temperature in the extremity.
Mm-hmm.
So what you see are paradoxic reactions to everything that you do. The extremity can't stay warm, the extremity can't heat itself, or maybe just the part of the extremity that's involved has this, and it responds in abnormal ways to cold challenge.
Mm-hmm.
You heat up another part of the body, you expect something else to cool down, and this doesn't behave the way you expect it to behave. That's probably better to diagnose this early autonomic dysfunction than any other test that we have.
Yeah, I've seen literature to that effect too. There was a study that came out in the early 2000s, Gulovich and Conwell. And I know Tim Conwell out of Colorado. And what they did was they started looking at the ability to pick up early stage CRPS, and their methodology was impeccable, and their statistics were in the 90 percentile for early stage. And they decided that they had four criteria that they used. There was delta T, meaning side to side temperature differences greater than a degree.
Mm-hmm.
They looked at disruption of the normal thermal gradients. That rainbow pattern that we usually see was very dysplastic and disrupted. They also saw they called it a thermal marker, where all of a sudden there was a rapid drop off in temperature. Everything looked normal to a certain extent, and then boom, from here down, everything changed. And then the last was the paradoxical warming on the cold challenge. And when all four were present, they were looking at something like a 93% accuracy rate in diagnosing CRPS, even if other tests were normal.
Right. And you'll find it earlier than the other tests.
Yeah.
Which is also really good. And then you can watch the physiology change as you make changes in the fascia that you can learn how to make.
Mm-hmm.
And you can also watch it change as you change your food, and your fascia becomes less inflamed from the toxicity.
Right. Now, and I think that's really important because often people think of thermography from a screening or a diagnostic standpoint in terms of identification, but
Mm-hmm.
this ability to monitor the physiological changes of your treatment's invaluable because we could do a lot of diagnostics and all of a sudden we find out we were wrong halfway into our protocol. Right? It's just we're not infallible. So to be able to monitor and see, did it respond to the intervention?
Right.
How well did it respond? Is there a new piece that's showing up that we couldn't see before because there was so much neural irritation and fascial irritation? It was being obscured. To consistently go in there and refine the diagnostic process using the subjective technology can really be invaluable.
Mm-hmm. There's another story that's really fascinating. This woman called me up several years ago, and she had a daughter who was now 5 years old, who had one leg about an inch shorter than the other leg.
Mm-hmm.
And the story was that when she was 2 years old, she had a lot of her thigh muscle removed for a cancer. And the leg wasn't growing like the other leg. And she wanted to know if I could use platelet-rich plasma, stem cells, growth factors to wake the leg up and get it to grow faster.
Mm.
We thought about that for a while. I called people from around the country. And what we decided to do was to bring her to Cincinnati and image her, actually take pictures of what she looked like with the infrared camera and see what that looked like. And what we found was the extremity that wasn't growing was 7 degrees cooler than the one that was.
Oh my gosh.
And we looked at that and we said, well, we can inject all kinds of things into her growth plate, but it really isn't going to help. She doesn't have enough blood flow to make anything grow. Well, we were able at that point to use infrared light.
Mm-hmm.
There's a lot of clinics now that are using infrared light, low-level laser, those kinds of things for pain. Well, one of the remarkable things about thermography and infrared imaging is that when you apply infrared light in the right place, the image changes very, very quickly.
Mm.
In the process of about 15 minutes, we watched her leg normalize temperature and match the other leg.
Wow.
A
From a
change from the
7 degree
inside.
difference.
So we use the thermography to be able to assess, when are you done with the infrared light? When is it achieve the therapeutic piece that you need it to achieve?
Mm-hmm.
So we were able to show her the protocol, and we've taught a lot of people how to use infrared light and what to do and how to integrate thermography with it. And so we sent her home with an infrared light unit with the protocol that we developed that day, because the protocol, we were able to see evidence of where do you put the laser, where do you put the light to make the change. And once you know that that's what happens, you don't have to have the camera to see. You can do it without the camera at that point. So we sent her home to continue the protocol once or twice a day. She came back in 2 weeks. We re-imaged her because we want to see what's going on, and found out that the leg is now warm all by itself.
Wow.
And now the temperatures are even. And that maintained for the next 5 years, and the leg caught up with the other leg just by doing the thermography in the very beginning, and then a tune-up maybe every 6 months for a couple years. And then she's been on her own with her leg and her nervous system and her blood flow doing what it needs to do, should do, knows how to do. And we could not have done it without infrared imaging.
Right. It sounds like you established the protocol using the thermography.
Correct.
That is the feedback to say how long, how much, is it effective? And once that baseline was established, you can go home, continue that protocol, and then use the thermography on a longer term basis in order to establish that the effects and the resolution was long term.
Are maintained, correct. Yeah. Because if a year goes by and she starts to drop her temperature, we know we've got to get on the ball and use the light again, and watch the scan and watch her change back.
Right.
Absolutely. Because and anybody using laser for pain has reason to have thermography in their practice. Because otherwise you really don't know. There's all kinds of, how much time do you leave it on? Where do you put it? Where's it going to be most effective? Well, you can't see the physiologic changes that are happening inside the body as a result of that energy going in without some sort of test like this, which is just a wonderful place to use it.
Right. Yeah, it's that objective feedback that you just can't replace. Yeah. So we've talked about a lot of things in the time that we've had, and I don't want to keep you too long because I know that you're a busy doctor. You've got things that you got to get back to. Just to summarize, we talked about the use of thermography, and not just the use of thermography. We talked about the importance of myofascial components to all pain syndromes, right? 80% or higher. And we've talked about how to use thermography in order to identify not only the source of that myofascial pain, but the complete referral zone that it might actually be incorporating. We talked a little bit about how that affects other conditions and other neuropathies. We talked a bit about CRPS and the effects there and using thermography there. Diabetics using circulation. And just an overall approach to using thermography to objectify what's going on. We spent the last few minutes talking a little bit about what people can do in order to relieve themselves from pain. You shared with us a couple of protocols. Anything else that you want to share with what someone can do to relieve pain they're in, whether it's acute, whether it's chronic? Just tips for the audience, tips that we can share with other doctors as far as management, so that we can really just elevate the profession here, because you've done such great work. We want to share this with as many people we can.
Well, thank you. You know, we're teaching a workshop on February 6th to teach people how to find pain, how to touch these parts of their body that are injured, and then how to change with your own hands the kinks that are in your body and make your pain go away. So it's February 6th. We're going to start at 9 o'clock in the morning and go till 4 o'clock in the afternoon.
And that's Eastern time, correct?
Pardon? That's Eastern time, correct? Yeah. It's going to be taped and recorded. So if you are registered for it, you can watch it as many times as you want and catch up if you missed part of it. We're going to talk for almost an hour on how is our body put together? How is fascia really formed? What is it? How do you find it? How does it get injured? And show people the anatomy that their doctor was never taught. And then after lunch, certainly not before lunch, we're going to talk about inflammatory food and the science behind food-based inflammation and what you really need to stay away from and why. And then through the day, we're going to cover headache, neck and shoulder pain, carpal tunnel syndrome, lower back pain, leg cramps, foot pain, growing pains in your child. So you're going to learn how to help yourself get out of pain. You're going to learn how to help your child, your husband, your mother, your sister, your friend. Your athletic trainer will learn how to work on you better if they do something and you end up in more pain. So universally helpful for so many people. And really, instead of talking about how to cope and how to manage pain, our conversation should be, how do we make it go away?
Absolutely. Absolutely. I know I'm going to register for that seminar. I may not be able to attend live, but I will take advantage of the recording. And I'll make sure all the people that I support know about it as well. We'll get this information to them before the class so they can register and certainly take advantage of all this. I think it'll be helpful for them in general, but also it'll help them with their thermography practices, seeing how that diagnostic process works and seeing how, and then I can elaborate with them a little bit more about how the thermography could help in that process and in those algorithms.
Awesome. Thank you very much.
Great. Well, thank you so much for taking the time, Dr. Blackman. We loved having you. Maybe we can do this again sometime. We can pick a topic and go in a little bit more of a deep dive. But just wanted to say thanks. And
Dr. Kane, it's always been a pleasure to work with you. And thank you very much. It's wonderful to get this word out to people.
excellent.